This will be going over airway management. So as we discussed previously, the best approach to airway management is typically going to be the one that provides an adequate airway with the least amount of risk for that patient. Airway management can and will include ventilation, oxygenation, or some combination of both depending on what that patient needs. So when we are talking about airway management, the first thing we know we have to do as part of our ABCs is to open that airway. And oftentimes, ensuring an open airway is just as simple as making sure that the patient's positioned to be able to maintain their own airway. So a responsive patient who's vomiting, for instance, or a patient who has a nosebleed or some other bleeding that can compromise that airway, put them in a sitting or lateral or recumbent position, and what this does is prevent that aspiration. So it prevents them from inhaling whatever liquid is going into their airway or into their mouth. This positioning also may be effective for your stroke patients who have impaired swallowing, or patients whose airway is narrowed due to epiglottitis or some other airway edema there. If you do this, make sure that you keep your suction available to assist the patient and be prepared to intervene further if that ability to maintain their airway diminishes. So constant reassessment here. Some manual airway maneuvers also can be used that take advantage of how the airway is structured, and what this does is it allows you to reposition, and so it can kind of move, like say the tongue or the airway opening itself, and can actually open up that airway. So these two maneuvers, for the most common two, are going to be your head tilt chin lift and your modified jaw thrust. Now with the head tilt chin lift, what it does is it adjusts it to a position that kind of moves that mandible to the front. And then this is going to line up the internal structures of the airway and prevents that obstruction of the glottic opening. Now this also is going to hyperextend the neck, so you cannot use it, or it's not at least the first choice, for patients with a suspected spinal injury. Okay, but if that jaw thrust does not provide adequate airway, may need to be used. Now, your modified jaw thrust is used to open the airway if you have a suspected spinal injury. Because it doesn't have much movement in that cervical spine, it's preferred over the head tilt chin lift. But it's also a little bit less effective than that head tilt chin lift. So, if you do this, number one, you have to keep your hands in place, because if you let go, then it will go back into place. But you're also going to need to reassess near continuously to make sure that airway is open and is staying open. When we have fluid or foreign bodies in the airway, they're going to obstruct the flow of air, and they've got to be removed before you can move any further. We've got to make sure that airway is open, right? So this could be blood, vomit, broken teeth, food, anything like that. A lot of other random objects. When you're doing your assessment, bystanders may give a history kind of consistent with a foreign body airway obstruction, like they were choking during a meal, or you may not even find that obstruction until you are unsuccessfully trying to ventilate that patient. But either way, it's really important to get a good history of that event to determine what course of action to take. Right, so noisy breathing is going to indicate a partial airway obstruction, as that air is forced through a narrowed airway or through fluid in the airway. That kind of harsh sound of stridor is going to indicate an upper airway obstruction. Localized wheezing in one lung indicates an area of partial airway obstruction just in one side, usually one bronchus or one bronchi. And then, of course, your fluid or bubbly, gurgling noises are going to be fluid in your airway. Position the patient on their side and let gravity help you out here. You're also, if you can see, if they've got a lot of big chunks or a lot of debris in the airway, you may want to use a gloved hand to sweep the matter out of the airway quickly if it's large amounts of stuff in there. If there is cervical spine injury suspected, use manual stabilization while positioning the patient. All right. And then after you've done this, suctioning will help clear any remaining residual stuff in the airway. Now for an adult foreign body airway, foreign body airways are going to result in either mild or severe airway blockage. A partial obstruction is going to let some air pass around it, but a complete obstruction is going to prevent airflow altogether. And it's really important to distinguish between a mild and a severe, because the treatment pathways are very, very different. So a patient with a mild foreign body airway may be coughing but still has air movement. So you'll see, your signs of coughing. It may be very obvious. They're choking, or if they're unresponsive, it may be unknown. So you must be prepared to do this at any time you're unable to ventilate a patient and you suspect that there could be a foreign body airway. So for mild obstruction, don't interfere with the coughing. If they're breathing and they're coughing, let them. Okay, let them cough. Let them continue and encourage them to continue to cough to try to expel the obstruction on their own. An oxygen mask, you put that on them, is going to potentially interfere with their ability to expel the obstruction. So what we're going to do is give oxygen by nasal cannula if needed. We're going to monitor very, very carefully because they can get tired. This is a lot of work trying to clear this airway obstruction. And a mild foreign body could progress into a severe foreign body, in which case we're going to change what we're doing here. All right? No matter what, even if they clear the obstruction on their own, they need to be transported because occasionally after the incident, you can have residual swelling in the hypopharynx that can occur even hours after the initial incident, so they need to be evaluated at the hospital. Now, for a severe foreign body airway, these patients are the ones that they can't talk, they can't speak, they're not able to cough. Okay, they may look cyanotic. They're not going to be moving any air. So we're going to use repeated abdominal thrust on these patients if they are conscious. So to deliver your abdominal thrust, make sure you stand behind the patient and put your fist just below their diaphragm on or around their navel. Then we're going to use your other hand and firmly pull your fist towards you and into their abdomen. And we're going to repeat this as the Heimlich. We're going to repeat this until the obstruction is relieved or the patient becomes unconscious. Okay? If you cannot put your arms around their abdomen, if they're very pregnant or extremely obese, then you're going to put your hands around their chest and perform chest thrust in the same manner instead. So either airway clears, you transport and monitor, or they become unresponsive. If they become unresponsive, then you're going to lower them to the ground and begin CPR. Okay, the chest compressions are going to increase that pressure in the airway in the same manner that abdominal thrusts do. So hopefully it will help expel that object and it will help ensure blood circulation. So we're going to try to complete cycles of 30 compressions and 2 positive pressure ventilations, just like with your CPR. But every time that you open the airway and attempt to ventilate, look in the airway and remove any objects that you see and continue these cycles until obstruction is removed. Then reevaluate from there. Now, pediatric foreign body airway is a little bit different. If it's a mild foreign body airway, we're not going to interfere very much like we would for an adult. We would encourage them to cough and encourage them to keep breathing. Now, if you go into a severe foreign body airway with pediatric, for a conscious child with a complete foreign body airway obstruction, we're going to perform subdiaphragmatic abdominal thrust the same way we would with an adult. And we're going to continue these abdominal thrusts until the object is expelled or the patient becomes unresponsive. Okay? For a severe foreign body, they become unresponsive. We're going to perform our 30 chest compressions. Then we are going to open the airway using head tilt chin lift or modified jaw thrust. We're going to visualize the airway. If we see a foreign body, remove it, but we're not going to do any blind finger sweeps because, their airway, it's a little more funnel shaped than adults are, and a blind finger sweep may actually push something back in there further into the airway. And then we're going to try to deliver 2 positive pressure ventilations and continue this cycle, 30 compressions to 2 ventilations until the object is expelled. With infants, for a conscious infant, we're going to use a combination of back blows and chest compressions. We're not going to do abdominal thrust on an infant. So what we're going to do is hold this infant prone along your forearm with their head in a slightly lower position, as seen here in this picture. Then we are going to deliver 5 blows to the center of their back. Then we're going to turn them over onto the other arm, and we're going to deliver 5 chest compressions as if you were doing CPR. We're going to continue alternating these 5 back blows, 5 chest thrusts, until the object is expelled or the patient becomes unresponsive. If that infant becomes unresponsive, we're going to use the same procedure for an unconscious child with severe foreign body airway. Suction is going to be the use of a negative pressure or a vacuum to remove liquids or coarse debris from the upper airway and occasionally from the lower airway if they have a intubation or if they have a tracheostomy site or tracheostomy tube in place. Now, our suction units can be either fixed or portable. They may be, manual or electric. Typically you'll see electric vacuums because they're going to work a little bit better. They're going to give a little bit more suction, but be aware that they are a little more aggressive and can actually cause some complications as well. When you're suctioning, you're not just suctioning debris or liquid or whatever, you're also suctioning oxygen out of their airway, so keep that in mind. Now, a properly functioning suction device should have an airflow rate of at least 30 liters per minute and generate a vacuum of no less than 300 millimeters of mercury when the suction tube is clamped. You've got a couple of different types of suction catheters. You've got rigid and soft. Your rigid suction catheters, usually it's called a Yonker or a tonsil tip catheter, and this is to suction just the oropharynx. It's not flexible, so it's not going to be able to move around as well, but you can control it a little bit better. It's a little bit larger lumen than your soft catheters as well, so you can actually suction larger amounts of fluid or vomitus or things like that. Now, a soft catheter is used for suctioning the trachea of the patients with an ET tube in place. They come in a variety of diameters and they're measured using French units. And these French units, the larger the French size, the larger the diameter of the suction catheter. So one French unit is equivalent to 0.33 millimeters. So a size 16 French is 5.3 millimeters in diameter, and an 18 French is 6 millimeters in diameter. Right, a 14 French is the typical size used for endotracheal suctioning of an average size adult patient. Now, when suctioning is not an emergency, such as routine suctioning of an intubated patient because the patient's going to be pre-oxygenated before you suction, because the suction is going to remove oxygen as well, and it's going to interrupt ventilations. But if a patient is in immediate jeopardy of aspirating fluids in the airway, do not delay suctioning for pre-oxygenation. All right. When suctioning is not an emergency, perform it for no more than 10 seconds at a time. If additional suctioning is needed, ventilate the patient again and pre-oxygenate the patient before suctioning. But if the airway is full of blood or vomit, clear the airway before you ventilate. Keeping in mind, you must do this fairly quickly. And you don't want to let that patient or cause that patient to aspirate fluids into the lungs by failing to clear that airway of its fluid. Now, as with anything, there are risks to suctioning. Okay, the risk, could be hypoxia or worsening hypoxia. It could cause trauma to the oropharynx if you're not careful, especially with a hard or rigid suction. It could activate a gag reflex. If you activate the gag reflex, whoop, there goes some vomit. Now you've got more stuff to deal with. It could also induce bradycardia through the stimulation of the hypopharynx, and this is even more common in your pediatrics. Whenever you're going to suction, there's also a risk to you, because you are generating force dealing with bodily fluids. So, as with any airway management procedure, minimum PPE should be gloves and eye protection, because there is a risk of it spraying into your face. And I'll tell you, I have had my eyes flushed because I had a patient vomit in my eyes, and I'm now a religious wearer of goggles. Have it happen once, you won't ever want it to happen again. Now, when you are inserting the suction catheter, make sure that you don't cover the side port. You want to, once you go in and you cover that side port, suction is going to be generated. So you want to suction as that catheter is withdrawn. Okay, if you are measuring with a soft catheter, you want to measure prior to insertion. If you cannot measure prior to insertion, you only want to insert the tip of the catheter as far as you can see into the oropharynx, and this will help avoid that stimulation of that gag reflex. Ideally, you should apply suction for no longer than 10 seconds at a time. Once you withdraw the suction catheter, insert the tip into a container of sterile water and suction some water through the tubing to clear it. And this is especially useful for your very viscous fluid, very thick fluid. And this will help keep the suction to the limits that it needs to be. Now, if you are going to be suctioning the lower airway, then you need to make sure that you are using sterile equipment and sterile technique. In the average adult patient, you're going to use about a 14 French suction catheter. In pediatrics, you're going to use whatever reference guide is available. If a guide is not available, typically a suction catheter that is approximately half the diameter of the internal diameter of the endotracheal tube will suffice. So while the suction catheter is in its unopened sterile packaging, measure it from the tip of the endotracheal tube or stoma to the level of the carotid, which is approximately right around the sternal notch. To account for that curvature of the upper airway, we're going to measure from the tip of the endotracheal tube, run that catheter from the tip of the tube to the corner of the mouth, around the ear, and then down to the sternal notch. And then you'll mark off, and this will be where you actually, how far in you will insert the suction catheter to. In patients who have really thick secretions, you may find it helpful to instill 5 milliliters of sterile saline from a plastic ampoule or flush into the trachea just prior to suctioning. What this is going to do is loosen the secretions, making them easier to remove. Your airway adjuncts. Once you have manually opened and cleared the airway, now you've got to make sure it stays opening. All right, you're going to need to make sure, of course, that you're monitoring the patient vigilantly and treating, hopefully, any underlying cause of the airway impairment. But you still must make sure, meanwhile, that that airway stays open and figure out what the best airway possible is and what's feasible for this patient. So our OPAs, or oropharyngeal airways, proper sizing is essential to effectiveness. If it's too small, it's not going to displace the tongue effectively, and if it's too large, it's going to obstruct the airway and may cause trauma to that soft tissue. So we're going to measure the length from the corner of the mouth to the angle of the jaw, just below the earlobe. If they measure between two sizes, select the size that creates the best airway without causing trauma. Now for your NPAs, or nasopharyngeal airways, these are good, can be used in patients when access to the oropharynx is impossible, so if they got trauma to that lower face or oral cavity. It can also be used in patients who have a gag reflex, but still need an airway adjunct to keep that open airway. The downside is cannot be used in patients who have severe head trauma or potential for basilar skull fracture there. So this NPA is inserted into the nose. Sizing, once again, is essential. It does not replace the need, to position that airway manually or to maintain those ventilations as needed. Our NPAs are going to be measured from the tip of the nose to the angle of the mandible just below the earlobe, just straight across there. When you're going to insert your NPAs, make sure that you are doing it bevel. You want to make sure that the bevel is oriented towards the septum. You want to make sure that you lubricate. You want to use a water-soluble lubricant prior to insertion, and insert it gently, following the floor of the nasal cavity. I find it kind of helpful sometimes to insert with just a very slight rotational movement, but not rotating all the way, just back and forth a little bit as you insert it. If you reach a point of resistance, stop. You cannot force it past this point of resistance. Some patients may have a deviated nasal septum or some other kind of variation in their anatomy that makes insertion difficult or impossible. Now with our supraglottic airways, these are going to be our non-visualized airways, or blind insertion devices as they're sometimes called. And there's quite a few of them out there. We're just going to talk about a few of them. The pros are they're relatively easy to use and can be inserted fairly quickly. And oftentimes, most of the time without stopping CPR or something like that if that's going on. They provide some aspiration protection, depends on which one you're looking at, but they vary, which ones you can use vary from state to state and from medical director to medical director. So this is just general information. Make sure that you are going to look at your manufacturer's directions and your protocols for insertion and use of these airway devices. So the first one we're going to talk about is going to be the King LTD, and it is height-based sizing. Now this device sits just in the hypopharynx, just above the glottic opening. And so with this, when they are inserted, they create this seal around the glottic opening. A cuff is inflated, and then positive pressure is created to force air into that trachea. That seal kind of adds a level of protection from aspiration, but it's not 100%. Things still can move. You still can have potential for aspiration there. Now, the downside of these, if you move a patient, it can dislodge the airway from its proper position, so make sure anytime you move that patient, from the floor to the stretcher to the ambulance, so on, make sure that you confirm proper airway placement and function after moving this patient. Contraindications for King are going to be patients who are under 4 feet tall and laryngectomy with a stoma. Now for your LMA, these are weight-based sizing, so there are typically more sizes available, and they do have pediatric specific sizes. Your contraindications, laryngectomy with a stoma. Now, once we have this airway open and secured, now we are assessing the need for artificial ventilation. So if they're in respiratory distress, we're going to give them supplemental oxygen. If they're in severe respiratory distress, failure, or arrest, we're going to give oxygen and either supplement their spontaneous respiratory effort or provide artificial ventilation as needed. Okay, so this artificial ventilation is going to move air into the lungs by positive pressure. There's several different types of positive pressure ventilations, and CPAP is included in them. It's a little bit of a misnomer because a CPAP does not give ventilations to somebody who is not spontaneously breathing. But it is good as far as improving the tidal volume. It's going to help improve oxygenation and reduce fatigue, so hopefully we can avoid intubating that patient and placing them on a ventilator. There's a lot higher complication risk once that occurs. So our main way that we will see and we will use for pre-hospital ventilation is going to be a BVM, or bag valve mask. And so what this is a self-inflating bag that's attached to a mask that creates a seal around their mouth and nose, and then has a reservoir for collecting oxygen. Oftentimes when you get them out of the bag, the ends will be popped in. Make sure you pull those out if they're not already pulled out. Just quick tug on each end and it'll put it into its properly inflated spot. Now, there are several different sizes, adult, infant, and neonatal sizes, but before you can use this, you've got to ensure that the patient's airway is open. You've got to make sure that the mask is going to cover the face from the bridge of the nose to the depression between the lower lip and the tip of the chin. So that way we've got the entire airway covered. And then we're going to ventilate at appropriate depth and rate. Now, technique, it is hard. This is one of those things that a lot of people think it's very easy, and it's not. Not to do it appropriately. You can cause significant harm to a patient if you're doing this inappropriately. When we are ventilating at appropriate depth, we want to make sure that we're minimizing any complications that can be associated with your positive pressure ventilations. Use just enough volume necessary to provide adequate tidal volume. Normal tidal volume is 5 to 7 milliliters per kilogram of body weight, but it's hard to it's very difficult to gauge how much volume is being squeezed in the bag. So squeeze the bag over 1 to 1.5 seconds until the chest begins to rise. Then stop. Any additional pressure is unneeded and usually leads to gastric distension and decreased venous return to the heart, which in turn will lead to decreased cardiac output. Okay, this rule of thumb holds true, regardless of the size of the patient. Watch for that chest rise and stop the ventilation upon moving the chest wall. As far as rate, all right, hyperventilation is harmful, hypoventilation is harmful. Typically, your adult patients are going to be ventilated 10 to 12 breaths per minute, except for in a couple of cases. This means that you're giving a single ventilation every 5 to 6 seconds. During CPR, the delivery of ventilations follows your AHA guidelines, so check with the most up-to-date AHA guidelines. Now, if you ventilate at a faster rate than normal, that leads to gastric distension and leads to excessive elimination of carbon dioxide. And we know both excessively high partial pressure of O2 and low partial pressure of CO2 can result in cerebral vasoconstriction. Cerebral vasoconstriction, decreased blood flow to the brain, problem. Low partial pressure of oxygen and high partial pressure of CO2 leads to cerebral vasodilation. So we want to make sure that we're staying within that acceptable range there. This is why capnography is so useful, because you can tailor to exactly where that patient needs to be to get that exact amount of oxygenation that they are needing at that point in time. Now, if you are assisting a patient who is breathing but is breathing inadequately, it can be kind of tricky. So our goal here is to increase oxygen delivery, reduce their fatigue, and improve their tidal volume. These patients, you may not assist every breath that they're taking, so aim to assist them with a rate of 10 to 12 breaths per minute, aiming for that adequate tidal volume. Positive pressure ventilation on a breathing patient is not easy at all. It requires very careful timing and communication with the patient. Tell them what you're doing. Tell them what's going on. They may not be able to tolerate the mask on their face. So if that occurs, reassess what we're doing, But keep in mind that inability to cooperate or uncooperativeness can also be a sign of hypoxia. Okay, so if they stop resisting assistance, they may either be tolerating the mask or they're deteriorating and unable to resist anymore. Another form of ventilation is going to be a manually triggered ventilation device. And so what this does is it delivers positive pressure without having to squeeze a bag or blow air into a mask. So the good thing of this is that it reduces rescuer fatigue. You can set the rate and volume of the ventilations and reduces your errors from over or under ventilation. Most of them have an alarm that indicates if you have excessive airway pressures. And a manually triggered device operates under high pressure and does not allow the provider to detect the sensation of increased resistance. So you need to be very, very careful because you're not going to be able to feel that compliance in the lungs when you are that you would ventilating manually there. Now with your manually triggered ventilation devices or a flow restricted oxygen powered ventilation device, this is using compressed air to deliver your ventilations. They can deliver between 90 and 100% oxygen up to 40 liters per minute. It's not always needed to use such high concentrations or such powerful concentrations. Okay, they should have a pressure relief valve that opens at approximately 60 centimeters of water. We're going to ventilate the patients with these only enough volume to cause chest rise at a rate of 10 to 12 breaths per minute. And we want to make extra sure when we're ventilating patients with chest trauma because it's very difficult or impossible to judge compliance when you're delivering these ventilations because you're not feeling the bag there, that increased pressure. So only use just enough pressure to increase the chest rise and fall, and be very careful and evaluate thoroughly for a pneumothorax. Also worth noting that the manually triggered ventilation devices are designed for adult use only. They do offer pediatric specific models, but require some extra specialized training in their use. Now for your automatic transport ventilators, these are used for patients who are requiring above BVM ventilation, but they're delivered in a device that's a hands-free operation. The advantages here is that it allows the rate and depth to be set, and then it does it on its own. You must check to make sure that the settings are safe and adequate for the patient, then reassess and adjust your settings as needed for that patient. The downside is, once again, you can't check compliance, so reassessment is absolutely vital here. For your contraindications, pneumothorax and diving-related lung injuries are going to be contraindications for the use of an ATV. For your CPAP, this is positive pressure, continuous positive airway pressure, so CPAP, and what it does is it's going to improve the airflow in a spontaneously breathing patient, right? BiPAP is another one that you may hear, and this is a bi-level positive pressure airway. These are more common at home or in the hospital, but typically pre-hospital we're going to have a CPAP. And what it is a mask that is sealed over their mouth and nose, and airflow is generated over the patient's pressure and basically what the patient's breathing against. And this is known as positive in-expiratory pressure, or PEEP. And what this does is it creates a higher pressure inside the entire airway tract, all the way down to the alveoli. And basically what this is like kind of like a bouncy house where they've got the little fan blowing and it keeps it inflated. Well, if that fan turns off, the bouncy house is going to collapse. Similar thing here with the airways. This airway pressure is keeping those airway tubes essentially open and ready to go, but if you turn off the pressure, they may collapse there. The CPAP is a great tool, but it is not a ventilator, so it's really important to note that it is not sufficient to ventilate a person who's not breathing. It can only improve the ventilations that are already there and taking place. CPAP is only indicated in patients who are responsive and able to follow commands, and it is not able to be used in a patient who cannot follow commands. Probably the most common use you'll see with this is going to be for acute pulmonary edema, but also can be beneficial for some asthmatic patients or things like that to help get that medicine down into their lungs. As far as complications, it can create a lot of the same complications that positive pressure ventilation can. It can create increased pressure in the chest and decrease your cardiac output and decrease in blood pressure. So use it in caution if you do have somebody who is hypotensive. CPAPs can be delivered using room air or oxygen. Typically, you're going to combine oxygen and room air to create higher levels of airflow with the CPAP. Once you've addressed the ventilation aspect of your airway, now we're going to look at your oxygenation. So we know that any and all patients with a complaint of dyspnea or who present in respiratory distress, failure, or arrest should get some form of supplemental oxygen. It can be beneficial to a patient with SpO2 of less than 95%. Remember, 95 to 100% is considered to be normal. Also worth noting that patients who have chronic lung disease sometimes will have lower SpO2 levels, 90 to 92, and that may be acceptable for them as well. Oxygen is a medicine. People forget oxygen's a medicine because it's all around us, but when we use it, it is a medication, and like all medications, there are certain guidelines that you have to consider and think about when giving this medication. Okay? Use this tool critically. Don't just do it because it's there and because we can. Know why we're giving it. It has very specific effects and mechanisms of action. This is not a cure-all. It won't fix everything. Oxygen in and of itself is vasoactive. It causes vasoconstriction and can actually decrease perfusion to some ischemic tissues in certain amounts. Hyperoxia is associated with increased morbidity and mortality in patients who are resuscitated from cardiac arrest. A little bit less serious side effect there is going to be, mucosal membrane irritation. It dries them out. It can create nosebleeds, things like that. Oxygen coming directly from a cylinder is not humidified. The humidifiers are there for a reason, because just straight, dry, essentially oxygen can be very drying on the mucous membranes and cause some problems there. There's also the potential concern that high concentrations of supplemental oxygen can decrease respiratory drive in some patients who have COPD. If they have become accustomed to increased levels of carbon dioxide, which is your normal stimulus to breathe, if they instead rely on decreased oxygen levels, it actually can diminish their ability to self-ventilate. But if the respirations diminish, the solution is to assist their ventilation rates, not to withhold the oxygen to support your aerobic metabolism. Okay? Never withhold oxygen from a patient who needs it. Now, oxygen is going to be supplied in small portable tanks called cylinders and in large tanks in vehicles and buildings. And cylinders are going to have a pressure regulator that's going to reduce the pressure to a level that is safe for us to deal with. They're also going to have a flow meter that allows for the amount of oxygen being delivered to be adjusted to their patient's needs. These oxygen cylinders are considered full when they have a pressure that is 2,000 pounds per square inch, or PSI. The minimum safe residual level is 200 PSI, so they should never be allowed to be emptied below that level. Okay? Different employers may have specific levels that they want you to refill. Typically, I try to refill a tank at 500. Gives you a little bit of leeway, but still within that safe range. Now, this pressurized oxygen first is going to pass through a regulator and then through an oxygen delivery device to give the oxygen to the patient. And like we said, that flow meter is going to be connected to the regulator to allow for the adjustment of airflow. There's two basic types of flow meters. You've got one that's a graduated tube that has a little metal ball that's elevated by the flow tube, and that's a little roll bar. These are more common mounted like on the walls of the ambulance or in an ER room or something like that. In the pre-hospital setting, it may be a gauge that displays the amount of oxygen, or a secondary dialer gauge to show the liters flow per minute. Most flow meters used at pre-hospital are going to allow delivery up to 25 liters per minute. But most time, if we get to 15 liters per minute, we're approaching 100% oxygen, depending on what delivery device. And remember, not everybody needs 100% oxygenation. And occasionally you will see regulators that also have a high pressure outlet that you can connect directly into with some CPAPs or other machine or transport ventilators, things like that, that allow for higher outputs of flow rate there. Your oxygen tanks or cylinders are going to be green or silver with a green band, and they're going to be labeled that it contains oxygen, and they will only accept an oxygen regulator. This is so that you don't mistake it for some other type of compressed gas tank and create problems there. We don't want to kill anybody there. Now, things to note with your oxygen safety. Oxygen enhances combustion when exposed to fire. Okay, so avoid your open flame or sparks when you're giving oxygen. Don't allow anybody to smoke near an oxygen cylinder. You will answer out at some point somebody who's on home oxygen and they're going to smoke a cigarette and they're going to burn their bangs off. They need to be transported. All right, this oxygen is a pressurized gas. So if you crack or break the metal cylinder or break the neck off, or where the regulator's attached to it, it's a missile. Okay, secure your oxygen tanks, secure your oxygen cylinders. Don't stand one upright without a proper securing device, and don't drop or drag or carry by the neck, by the regulator, an oxygen tank, because if you break it, it's a missile. Now, these oxygen cylinders need to be hydrostatic tested periodically to make sure that that tank is still good, make sure it's still acceptable to be used. And petroleum products, they can react with oxygen, so don't use grease or adhesive tape on any oxygen cylinders or regulators. As far as oxygen delivery, you've got non-rebreathers. This is probably one of the more common. These are the two most common ones that you will see pre-hospital, non-rebreather, nasal cannula. Your non-rebreathers are going to allow high concentrations of oxygen because of that reservoir bag, and it's got a simple flap that acts as a one-way valve to direct exhaled air and oxygen flow. A non-rebreather is a good choice for patients who have adequate ventilations but need high concentration of supplemental oxygen. You never use this on a patient who has inadequate ventilations. You're going to use a BVM instead. Downside to the non-rebreather, some patients may feel suffocated by having something placed over their mouth and nose, so oftentimes your reassurance can kind of calm them down and help them to accept the mask if needed. Right? For your nasal cannula, this is a length of tubing that kind of looks like almost like a lasso with two little prongs on it. And what this does is those prongs sit in the nares to deliver your oxygen. It's a low flow device, and it provides oxygen concentrations between about 24 to 44% of oxygen at flow rates between 4 and 6 liters per minute. In order to deliver oxygen by the nasal cannula, they must be able to breathe through their nose. Okay, so if you've got a patient with a broken nose who can't move air through their nasal passages, they're not going to do well on a nasal cannula. These are good choices for patients who have mild dyspnea and no more than mild hypoxia, between about 90 to 94% SpO2 on room air. Your Venturi masks are designed to mix specific amounts of ambient air and oxygen to achieve a specific concentration of oxygen. And that, as you can see in that picture, that they've got different adapters that are going to deliver different amounts of oxygen mixed with ambient air. These are good for patients with longer-term oxygen administration, COPD, things like that. Your simple face mask is not going to have a one-way valve or reservoir bag, and this is going to deliver lower concentrations of oxygen, typically flow rates between 6 to 10 liters per minute. And the actual concentration of air delivered depends a lot on respiratory rate, how well the mask fits, and the amount of room air that's mixed in with the ventilations. Your tracheostomy masks are going to be there to provide oxygen to patients who have a tracheostomy tube or stoma and who do not require your positive pressure ventilation. These typically allow your airflow rate of 8 to 10 liters per minute of oxygen